What's up, everybody? Dr. Andrew Fix back for another episode here on the Code. And I'm being joined by a coworker of mine, a friend of mine, Dr. Nate Henry this morning. And this is going to be an awesome interview for you guys, especially those of you who have ever been clients of ours or any other physical therapy practice for that matter that have experienced or been wondering about dry needling. Nate and I are going to get into dry needling a little bit on this episode. And for a little bit of a background before Nate introduces himself, Nate is a 20 plus year Army vet. He joined our team here at Physio Room less than a year ago, and he's actually heading up our new location down in Colorado Springs. And it's awesome that he's joining us on here because he actually has the opportunity to speak and educate across the country in a continuing education capacity and in a university setting in the physical therapy realm. So, Dr. Nate, thanks so much for joining me this morning, man.
Hey, Andrew, this is going to be fun, man. Appreciate a chance to get to talk to you.
Yeah, absolutely. Yeah, and every time I get to talk to you, it's always great, but especially like when I feel like I have the opportunity to learn, whether it's from you or someone else, I always get really excited about it. So, sure. And I know this is an area that, dry needling, something I've been doing for quite a while now. I think I got out of physical therapy school in 2015, started dry needling in 2016. Sure. And, but I mean, you have quite a bit more experience with it than myself with all your teaching and everything. So I'm excited to get into this conversation. Nate, will you do us a favor for all the people that are tuning in to listen to this? First of all, really appreciate your guys' time tuning in here and hanging out with us on the Code. We really hope we bring you some valuable content with this episode and all the episodes that we do. But Nate, will you share a little bit more about your background, sort of, where you came from? You spent extensive time in the military. And how did you get into this, physical therapy kind of educator position that you're in?
Yeah, sure. Well, I started off in the Army as a logistics officer. So I ran supplies for about 7 years. And that included a stint in Iraq where I managed food and water for over 25,000 soldiers. And after I spent about 6 or 7 years doing that, I'd had about all the fun I was going to have doing that. So I looked at some other options within the military, and the Army offers a physical therapy program for active duty folks. And I started that program in 2007 and graduated in 2010. And I didn't know at the time, but when I applied to the program, it was actually a top 5 program in the country. So it's a fantastic education. After 2010, I kind of decided, man, I am done with this education thing. I mean, I appreciate education. I really kind of pursue education, but I do have to admit, I'm not all that good at it. Just the kind of concentration that is required to study and to pay attention in class. I honestly just really struggle with that. But yeah. Somehow I've managed to be successful. It usually takes about twice the amount of time as some of my peers. But anyway, that's neither here nor there. I ended up in Georgia at Fort Benning, which is one of the largest training bases that we have in the country. And I spent some time with some airborne soldiers, with soldiers that were trying to become infantry officers and armor officers. So those are the guys in tanks. I spent some time with the airborne school, people learning how to jump out of airplanes. And you see all kinds of injuries in that situation. We had one of the foremost ankle surgeons in the country there at Fort Benning. And I talked to him one time. He said, I'm never leaving Fort Benning. I'm like, why? This is a little podunk town. You could practice anywhere. He's like, I'm never going to see what I can see at Fort Benning, Georgia, because we have airborne school there. We have ranger school there. We've got some officer training there. And he sees just complex cases, very interesting cases. He loves it. Anyway, I spent some time training there and practicing there, and was able to treat soldiers everywhere from rangers to basic trainees, from essentially the most elite to some of the we say couch to 5K. In the civilian world, it's couch to basic training for a lot of these kids nowadays. And so I got a lot of experience doing that. In 2015, the Army sent me to Florida. I actually had to apply for that job because it was with a special forces unit, and got to treat some more elite soldiers. And they wanted me to be the best trained that you could be out there. So they actually sent me for a 1-year fellowship in manual therapy. And that's where my reintroduction to education was made. Again, not something that I typically pursue, but this one just kind of fell in my lap. And
Yeah.
that turned out to be one of the best experiences for my career, not only clinically, but also kind of business wise, because I saw just how effective we can be if we've got just a little bit of extra training.
Mm-hmm.
After that, I kind of said, you know what, I'm done with school. I just want to go to Colorado and finish out my time in the military. But the Army dangled one last carrot in front of me, and that was to go to West Point to earn a Doctor of Science degree,
Mm-hmm.
a terminal degree that allows me to become a professor, teach somewhere. But they also, at the same time, put us through a sports fellowship program. So I'm one of the rare therapists that is, I have 2 doctorate degrees. I've done 2 fellowships. It's kind of rare for anybody to have 1 fellowship, and I've done 2 of them. And I've done 2 board certifications. So this guy that isn't all that good at education, I'd have to say I'm ridiculously educated.
Yeah.
Some of that is my
Yeah.
fault, and some of that is the Army's fault, but hopefully I can use that to the benefit of our patients and of our staff now at Physio Room.
Yeah, totally, totally. Now, so you and I both spent a little bit of time in Georgia. Now, you were there, I think, a little bit before me, but that's actually where I did my orthopedic residency program. What part of Georgia is Fort Benning in?
It's in Columbus, Georgia, about 2 hours south of Atlanta.
Okay, yeah, in Columbus. That
right on the
sounds about
Chattahoochee
right.
River, man.
Yeah,
I do
exactly.
love that dirty water. It was fun.
There you go. Okay, and it was 2010, right? You graduated from Army Baylor PT
Yeah.
program,
Yep.
and yeah. So when you started, sort of working as a physical therapist in that setting, what were some of the I don't know if challenge is the right word, but like, what were some of the things that you saw in the world of physical therapy that you knew like had to change, right? Like, and you
Sure.
continue to get more education. I know, without even asking you, I know the way that you practice has evolved from 2010 to 2022. So like, what were some of those things that you saw that you felt like needed to change in order for us to be more effective? And what are some of the major changes you've made over that like time span?
Oh, early on, well, one thing that I can appreciate was in physical therapy school, our program director, we were the first class that he did this to. He came in one day and he said, look, all of you need to be certified strength and conditioning specialists. So and as a program, we're going to pay for your CSCS, right? From the National Strength and Conditioning Association. And probably about half of my classmates were pretty upset. I mean, I was excited. I got into physical therapy for exercise, but some of them were like, hey, I did that. This was not what I signed. I didn't sign up to be a strength coach.
Yeah.
But I'll tell you, when I got to Fort Benning and got to my first clinic that I was working in,
Mm-hmm.
I recognized pretty early that we were not challenging our patients enough.
Yeah.
And don't get me wrong, there's graded exercise is important, and deliberate progression and introduction to movement, it needs to happen. But I've seen this now over the past 6 years that I've done continuing education. I teach about between 20 and 50 physical therapists every month in the continuing education setting. And it has surprised me how many are they consult me about their case, or they ask a little bit about what they should be doing with their patient. And I ask them they're 6, 8, 10, 12 visits into the program, and they're still doing for rotator cuffs and little TheraBand, external rotation exercise. I'm like, holy cow, guys, we need to understand exercise progression and load a lot better
Mm-hmm.
and apply it to our patients a lot sooner. And of course, there's some exceptions to that, but for the majority of patients, that needs to happen. And in our
Yeah.
profession, we are way too slow to apply it.
Yeah.
So that's in 2012. I was introduced to CrossFit actually in 2006, 2007, when I was at Fort Lewis in Washington. I met the guy that opened the eighth CrossFit gym. And then when I was in Georgia, I decided I should get my CrossFit level 1 certification. And
Yeah.
the guy teaching it was that guy that when my wife and I both earned our level 1. And here's the deal: we can poo-poo CrossFit. I mean, lots of people, there are on occasion some gyms and some coaches that they don't know what they're doing.
Mm-hmm.
But I will tell you this: I've been to at least 30 gyms across the country, and it has been the exception. Very few have been, I would say probably 2 that I went
Yeah.
to out of those 30, where I'm like, oh, I don't know. These people don't really understand. But a majority of them are very, very, very good.
Yeah.
And they're applying load to patients, and they're scaling exercise. And in some cases, in fact, in many cases, they're doing it better than some of my colleagues in the physical therapy world. So uh, that's in 2012 when I took that course. I was like, yeah, we can be pushing our patients a little bit better. And
Yeah.
there's a little bit of a conflict between CrossFit and the NSCA. But I feel like I've been able to kind of massage those both into place in my practice,
Mm-hmm.
and
Mm-hmm.
apply the principles from both approaches.
Yeah, I love that. And I love, I think it's awesome that your program and the instructors and professors and whatnot in your program decided that they were going to do that and sort of, offer you guys the opportunity, but more so like say, hey, we're going to pay for you to go do this and to get that CSCS, because that was actually a decision that I was trying to make when I was going into physical therapy school. I
Mm-hmm.
took the undergrad that, trained me with the knowledge necessary to probably go study for and take and pass that CSCS exam.
Yeah.
But for whatever reason, probably just a couple $100 of finances at the time, I decided not to do it.
Mm-hmm.
And then when I got through PT school and got out, that was still a decision that I was trying to decide, like, do I want to go do this? Should I go do this? And I talked with a couple other PTs, and at that point in time, I never really envisioned that I would leave the practice that I was with. I thought I was just
Sure.
going to stay in my first place of employment forever, and keep changing roles. And I was struggling to see how having the CSCS would really change or make
Benefit.
an impact on.
Yeah.
So I was like, well,
Yeah.
why don't I just get the knowledge and maintain the knowledge, but I don't need this certification. I don't need these
Yeah.
letters. And that's kind of where I feel like I'm at now. I don't know that there's necessarily anything that I can't do because I don't have the CSCS while having the degree that I have. However, I agree with you 100% that I think as a whole, one of the things that happens in the world of physical therapy is underloading and underutilizing exercise progressions. And I've met many trainers in my life, coaches, trainers, whatever term you want to use, that are far better at prescribing movement and prescribing load intentionally, that really can create changes. Well, now one thing I'll say that it feels like in the world of physical therapy is we are really good at regressing exercises,
Mm-hmm.
and we're
Yep.
really good at scaling things back and finding things that people can do comfortably. But then once we hit that point where it's like, okay, now they need to move on from those things, maybe they're out of pain. Now what do we do? Right. And
Yeah.
and I think that's where sometimes people get stuck. But okay,
Hey,
so
let me
yeah,
just
yeah,
chime in on that real quick, Andrew, in that
absolutely.
I don't totally blame the physical therapy world for that.
Mm-hmm.
Part of that is insurance driven.
Oh, sure. Yeah.
And when we have that, when insurance then says, okay, we got you back to walking, well, the patient was running before, right?
Yeah.
So, and we want to get them back to their function, at least what they were before. At Physio Room, as we go through our 3-step process, right, of
Mm-hmm.
reset, restore, reload. Unfortunately, in the insurance based world, they get you to reset. They might get you to restore, and then insurance says, okay, we're done,
We're done.
right?
Yeah.
And in our playground, it's like, no,
Yeah.
we want to reload you and get you beyond where
Yeah. I
you
think
need.
that's a good point that you make there, that, it's not necessarily the provider's fault or the profession's fault or anything like that. It's a whole system thing.
Yeah,
And,
right.
sometimes trying to play within the lines of that system impacts how clients get cared for,
Sure.
and what we're able to do with them, unfortunately.
Yeah.
Um, Okay, so that's talking about load. When was it, Nate, that you remember getting like certified in training in dry needling for the first time?
Well, hopefully this story isn't too long. I had a buddy that got trained in dry needling in 2012, and he came to my office, and I said, "Hey, I'm having some hip gluteal issues." He's like, "Hey, let me try this new thing that I learned."
Mm-hmm.
And he took some long needles, he put them in my gluteal area, and then he did this kind of in and out fast technique, a pistoning technique.
Yeah.
He got and honestly, it hurt while he was doing it. And then he got done, and I was sore for a long time. And I remember these words have come out of my mouth. I said, I am never going to do that to a patient, you
Mm-hmm.
know. And in the military, we get about it depends on the unit you're in, but you'll get a little bit of money each year for your continuing education
Yeah.
purposes. And unfortunately, in about 2013, we were going through some budget cuts, and my boss came up to me and said, "Hey, this year for continuing education, you get $100." I'm like, "Ooh, wow, $100, thanks."
Don't spend it all in one
Don't
place,
spend
Nate.
all in one place. So he came up to me a couple of days later and he said, "Hey, I have a friend that teaches dry needling for this company. Um, but he said he could do kind of an off circuit course for us. If we
Mhm.
all pool our $100, we'll get $500 together and we'll buy his plane ticket and he'll come and teach us the course for a couple of
Mm.
days." I'm telling you, Andrew, that is the only way that you would have got me into a needling course
Oh,
is
wow.
that kind of setup, you know. Anyway, he came, he taught us, and he taught us muscle specific
Yep.
pistoning technique, muscle by muscle throughout the body. And in the physical therapy world, we've kind of done it to ourselves in that we've called it uh, muscle or trigger point dry needling, right?
Yeah.
So that means it's muscle specific. But when you look throughout the literature, it is not, it's not just muscle. In fact, muscle is probably third or fourth on the list of what you're treating. I took my second course after I did that. I mean, I did apply that technique and I applied it in my military practice, but I was also running a cash pay physical therapy practice on nights and weekends out of our local CrossFit gym. And I
Mm-hmm.
started applying this modality there. And those those results were actually pretty good, even though I was using that very aggressive technique.
Yeah.
So I decided I should take another course. In 2014, I took another one from Dr. Ma. It was his course, but it was actually taught by Dr. Sue Falsoni, who was, if you don't know, she was the first head female athletic trainer in Major League Baseball. And she's also a physical therapist. And she was trained by Dr. Ma. She came out and taught a course. And that's where I started to learn that we should treat the region, not
Mm-hmm.
just the muscle that we're trying to address, right? And then in 2016, when the Special Forces Unit put me in fellowship training, that's when I was introduced to the American Academy of Manipulative Therapy. And, you know, I really appreciate those first two courses that I had. They were both very good. And they did change my practice. But I'll tell you, American Academy of Manipulative Therapy, like I said, that has been the most effective thing or
Mm.
had the most effect on my career
Yeah.
because they really meld the art and the science of therapy.
Yeah.
And with needling, they blew the blinders off for me and said, "Look, this is what's happening." They took me down to the microscopic level of what's happening when we stick a needle in the body. And we could see what was happening, the mechanisms that was happening with the application of a needle in tissue. And
Well,
it's
let's
way more than just treating a muscle.
well, since you brought that up, I'd love to
Yeah,
expand on that just a little bit. And maybe we do this in kind of a twofold manner. Explain it at a high level and then maybe bring it down a notch or
sure.
two,
Yeah,
because like you just have kind of gone through, there's different ways that you can apply dry needling, right? As the practitioner. And I'm assuming people that are listening to this podcast have probably experienced different things. I've
sure.
experienced different ways of being needled as kind of the client. I've done different ways of doing the dry needling as the provider. And just like you sort of said, like the way that I learned initially in 2016 was not the trigger point pistoning kind of technique.
Yeah.
And I've never really had that, that's never been my like first go-to or preference.
Right.
But most of the physical therapists that I have come in contact with, that is how they were trained, and that is how they
How they're
learned.
trained. Yep.
So, okay, so whether you're dry needling the muscle, you're dry needling the trigger point, maybe you're pistoning or not, or you're treating the region like you mentioned. First of all, like, what the heck is dry needling? And two, what is happening when you insert the needle into the skin, into the tissue? Like, what kind of cascade of effects is that causing that maybe helps produce some of these results that clients and providers see?
Yeah, sure. So, I typically explain this to physical therapists, but I also explain this to patients. And I think probably in our setting, you and I talking right now, and given our audience, we should probably just talk about it as if we're talking to a patient.
Right? I think so. Yeah, sounds great.
So when first of all, the tool that we use, it is an acupuncture needle. Mm-hmm. Some are branded as dry needles, but by and large, they're an acupuncture needle. Now, acu means skin. Puncture means pierce. So we are piercing the skin when we practice this modality. And depending on what state you're in, physical therapists are allowed to do that. Mm-hmm. In the state of Colorado, we were one of the first states that you could dry needle in. So we do that. Now, I will not say at all that I do acupuncture. Right. And the main reason why is because, and please don't let me oversimplify acupuncture, but I am not trying to balance someone's chi, trying to balance the yin and the yang in their body and move chi along meridians according to an acupuncture map of the body.
Right.
And I'm not disparaging that in any way. I have friends and family members that have benefited from that kind of treatment.
Yep.
But for what I know and what I do, I'm approaching things from a neuromusculoskeletal approach, a Western medicine approach, and not an Eastern medicine approach that is typically acupuncture.
Yeah.
So just it's the same tool, it's just two different approaches, right? So when I apply a needle to somebody's body, I'm trying to affect the anatomical tissues of the body. And again, I'm not trying to balance their yin and their yang or move chi along their body. So what does needling do when we stick a needle in the body? And really, there's a great paper on this for any of your folks that are scientifically minded. You want to read a paper from 2016 by my good friend, Raymond Butts. He calls it 7 years of his life that he'll never get back, or not 7 years, I'm sorry, 7 months. 7 months of his life that he'll never get back, because he spent a lot of time scouring the literature at every paper, looking at the mechanisms of what happens when we stick a needle in the body. And he wrote it up, and we've got that guide. We have the paper. So you don't have to go look up all that stuff yourself. Raymond's already done it, right? And his paper describes probably about 6 or 7 specific things that happen when you stick a needle in the body. But for what I typically use it for, I boil it down to 3 things, okay? Number 1 is we're going to introduce inflammation on purpose. And I know that seems a little bit counterintuitive, but for somebody that has a subacute injury or a chronic injury, let's say chronic low back pain, they're simply not getting through the 3-step process of how the body responds to an injury. A inflammation, then it goes through a repair, and then it goes through a remodel. That's what happens when you sprain your ankle. That's what happens when you injure your shoulder. That's what happens when you have neck pain. It should be, most people are getting better after their injuries after about, I don't know, 5 or 6 weeks, maybe even less, and it's because they went through appropriately inflammation, repair, remodel. In those chronic type injuries, they're stuck in this kind of inflammation repair phase, and they're not getting over the hump. So all we're doing at Physio Room is we're sticking a needle in that same area that they have the pain, that they have the injury. We're reintroducing inflammation. It's very focal, it's very little, but we're reintroducing it now as we apply our stretch and our exercise and our reset and restore program. We hopefully get them over that hump of get them from inflammation to repair to the remodel phase. So that's very simply one of the first things that happens when we stick a needle in the body. Number 2 is we reset the muscle, right? It's kind of a long explanation. And for anybody that's interested, I'd be delighted to, tell you the whole thing. But the bottom line is this: you have a nerve coming down to the muscle, and that nerve tells the muscle to contract. In a muscle that is damaged, maybe it's in a hypoxic environment or an acidic environment. Once it contracts, it doesn't go back to its resting length. And there's several chemical processes that we could discuss that include, the acetylcholine and the calcium and the potassium and all that stuff. But bottom line is, it contracts and doesn't let go.
Mm-hmm.
And that's what forms kind of what we call a trigger point in the muscle. This has been observed. When we stick a needle in a muscle group, it will restore its resting length. It just kind of relaxes.
Yeah.
And again, there's some chemical processes that we think that are happening for that to cause that. Particularly, it clears out acetylcholine between the nerve and the muscle. But that's it does happen. And I've actually observed it in clinic, right?
Yeah.
Patient comes in, taut muscle, stick a needle in there, it relaxes.
Totally.
Now, there's a whole bunch of research that is beyond that, and some of it even suggests that doesn't have anything to do with the muscle, but rather the connective tissue around the muscle.
Mm-hmm.
But it's fine. Patients don't care about why; they just care about the result.
Totally.
And so we can get a muscle to calm down that way.
Mm-hmm. Yeah.
Lastly, and probably the most important, is we can affect the body's ability for pain control. And the way that's done is with the body's own opioids. Now, we've heard of this opioid epidemic where we're being prescribed too many opioids. People easily get addicted to opioids. They're an effective drug for pain. Unfortunately, they have way too many side effects.
Yeah.
Now, when we take an acupuncture needle and we stick it in the body, there are these little cells within the body called fibroblasts. And we can get, if we manipulate the needle appropriately, we can get those fibroblasts to stretch out. Those release a little drug called anandamide. Anandamide is the genetic code to produce opioids, and the body produces its own opioids. It's not that far off from when somebody gets a massage. You get the tissues are pushed and stretched, and that actually affects those little fibroblasts to release a little bit of anandamide, and that's why you feel good.
Yeah.
But with needling, we're maximizing the amount of anandamide that's released from those fibroblasts. It's much more than what a massage can do.
Mm-hmm.
It's very focal, it's very drastic, and we get a maximum release of anandamide to produce opioids. So really, when I needle somebody, it's one of three reasons. Either I'm trying to induce the inflammation, or I'm trying to reset the muscle,
Yep.
or I'm trying to release some anandamide to produce opioids so that they get a pain relief effect. One other that I should probably throw in there, that there have been some brain scan studies while people have been needled, and it shows increased activity in a little area of their brain called the periaqueductal gray, and that controls pain. Let's say you have pain in your elbow, it actually stimulates a portion in your brain that says, that they call them descending pain pathways. Those descending pain pathways say, hey, you're not feeling this pain, right?
Yeah.
So it helps control pain that way. Now, are we interested in covering up pain? Not at all.
Right.
But our nervous system gets very good at feeling pain, especially if you've been feeling it for a long time. All we're doing is resetting that and saying, hey, you're not feeling this quite as much as you thought you were. And it helps quite a bit, actually. So those are the three things primarily that are happening.
And I think that explanation was great. And I agree with you. Generally speaking, a lot of patients don't necessarily care to know all of the science, but they want obviously their symptoms to feel better so that they can perform and function better. But I think more so at Physio Room compared to where I worked in the past, I do have clients ask me much more like, what's happening? Like, why does this work? I've had dry needling before, or I haven't had dry needling before. What exactly is going on? Yeah. And you're going through that explanation just kind of took me back to residency, because I feel like I remember I had to basically be able to explain all that stuff.
Yeah.
Like you just said, for part of my
Yeah.
residency, including the ascending and descending neurological pathways and whatnot, that was a huge part of it.
Yeah.
And I think the things that you mentioned, reintroducing that intentional inflammatory response to try to
Yep.
promote a healing response, that neuromuscular kind of reset to, change things, change the tone, the guarding, whatnot of the muscle, potentially through some of those chemical processes that are triggered by doing that, and try to produce this pain relief effect from the body, are probably three of the main things that I explain to clients too when
Yeah.
they ask me that. And then you already kind of went down the acupuncture compared to dry needling route just a little bit. That's
Sure.
probably also one of the most common questions that I get from people is, okay, we're going to dry needle my, my calf or my shoulder or whatever. Is that the same as acupuncture? And I'm like, well, the needles are the same, but
Mm-hmm.
let's sort of briefly talk about the difference. And, I'm not an acupuncturist, but this is my understanding, and I have had acupuncture a few times, and this was my experience. And then this is the dry needling experience. So no, I thought that explanation was awesome. One question that I wanted to ask you is, actually, I guess I have a few, but I actually was doing a little bit of dry needling on myself this past weekend, right?
Yep. Yep.
And Nate and I were just talking off the air about how I've been having some hip pain. And so I decided I was going to dry needle some of the muscles kind of superficially there around my hip. And I was sitting, my wife was hanging out with me in the living room. I was sitting down, on the floor, but with my back like supported up against our island countertop. I had my leg kind of supported by a pillow so I could keep things kind of relaxed. And I was dry needling some of the muscles around my hip. And for any of you that that know much about the hip, one of the muscles that I decided to needle was called my TFL. It sits right there by like kind of where your pocket is, and your IT band comes down the side of your leg, kind of off of that region. And I needled that. I needled a little bit of the very upper proximal part of my quad. And one of the things that I noticed is, because I was in a seated position, Nate, and a lot of times when we dry needle clients in the office, they're lying down, whether they're lying on their stomach in a prone position or face up in a supine position, side lying, whatever, but they're lying down typically. So I do the needling, I do a little electrical stimulation in addition to that, and I let those needles sit in there for multiple minutes. And then I decide to take them out. And right around the time when I was turning off the e-stim, deciding I was going to take these needles out, I started to feel this very large entire body kind of like nervous system effect, right? I started getting a little, yeah, totally. I started getting a little lightheaded. I'm typically someone who, my palms and my feet will get kind of clammy while doing dry needling, but I was having that effect on my whole body, not just my hands and my feet.
Yeah, sure.
And yeah, so what I wanted to ask you is, sometimes we see that effect with clients. Sometimes I feel that with myself, but not always. And this was, quite frankly, the most significant of that kind of nervous system effect that I've had.
Yeah.
And why does something like that happen? Because that's sometimes I explain to patients, you may feel little lightheaded, you may feel a little kind of like, overwhelming kind of nervous system effect, because this is affecting your whole body, even though we're needling this one area.
Sure.
But sort of just go into that for just a moment there. Like what kind of can cause that? Does that mean anything?
Yeah, I mean, quite simply, it's a downregulation of the nervous system. And I had a lot of patients in Florida with this special forces group. You got to understand, these guys are training hard all the time, not just working out. They're training their craft, right? All the time. They don't sleep a lot sometimes. And when we could bring them in, even though it might have only been 15 or 20 minutes, bring them into the clinic, help them out with a long-term injury that they've had, throw some, and we would do some education, some exercise, maybe some manual therapy, but then we'd also do a dry needling treatment. Those guys would they would rack out for the whole 10 or 20 minutes of treatment. It's one of the best naps that they've had in a long time.
Yeah.
So remember, we talked about, it's not only descending pain pathways that we're affecting in the central nervous system. We're down regulating the entire nervous system.
Yeah.
And dry needling is not the only thing that happens with. I mean, you may have heard of patients that I know every massage therapist will tell you, wow, this patient just ended up sobbing on my table, right?
Yeah.
My
Yeah.
table in a
Yeah.
regular massage, I mean, the same kind of thing is happening there. And, I have had patients crying on my table after a needling treatment. It wasn't because it
Yeah.
hurt. It was because it affected their nervous system like it did, a complete release of tension, of stress.
Yep.
Uh, so yeah, that can and does happen. It sounds like it happened to you a little bit.
Yeah, for sure. And I think that that kind of process in general, that whole nervous system effect. I've had numerous clients fall asleep while they're lying on the table, because I tend to be somebody that I leave the needles in for several minutes. I don't just like, piston the spot and then take the
Yeah,
needle out right away.
yeah,
So they're lying there, and I've had many people fall asleep. I had in my first dry needling course, actually, one of the first things that I remember we had to do was to kind of make sure that we were brave enough to do the dry needling, like to actually insert the needle. The very first person we inserted a needle on was ourselves.
sure.
And we're
Yep.
sitting at the table. We just needled our forearm muscles just with one needle. And one of my residency or dry needling course, classmates, he actually fainted
Yeah,
during that procedure. He started to feel a little lightheaded, and he just decided he needed to put his head down. And he waited there for several minutes, and everything was totally fine. But it's just one of those examples of that down regulation that you're talking about, and the
yeah,
effect that it can have on the entire system.
yeah. And I don't want to scare patients away with that either. I have had actually I haven't had patients faint before. I know colleagues that have. I have had students when we're teaching needling, have had that happen before.
Yeah.
Um, Here's the deal. When I bring a patient in, we're going to needle them. I explain it to them that I believe it's part of their plan of care. They are in control the entire time. I've had patients tell
100%.
me before saying, I don't want to do that. Oh, okay, let's figure out something else for you.
Yeah.
Or a patient that might be hesitant, but they do want to try it. Tell them, look, I'll go one at a time. I'm going to insert each needle. Most of them, you're probably not even going to feel it. If you do, it's going to be very tolerable.
Yeah.
Nothing should be downright painful. If it is, I just pull it out and we're done.
Done.
It's easy. And a majority of patients are okay with that.
Yeah, I would agree with you totally. And by me saying that, telling that story, I too
Yeah.
am not trying to scare anybody. In fact, I actually think it's, to me, with my scientific brain, it actually makes me like kind of want to do dry needling more, knowing that it
Mm-hmm.
has this effect on the whole body and not just
Yep.
on this one spot. Because I'll tell you, even though I was pretty uncomfortable for about 60 or 120 seconds when I was having that like down regulation experience this past weekend, the rest of the day I felt much better.
Yeah.
And it was very interesting. Like the pain that I was experiencing changed totally. I still had some sensation, but it was a very different sensation. It was very less localized, less sharp. And it was more of just like a global kind of like I felt and was aware of my hip, but it wasn't like
Yeah.
hurting as much.
Yeah.
And
Yeah.
so that was definitely something. And just like you said, with clients in the office, I tend to find that most people, when we offer up the opportunity or the recommendation that, hey, I think we should do dry needling in this circumstance, they're totally in control, and two, we wouldn't be recommending it if we didn't think it would be beneficial for them. And
Sure.
that's
Exactly.
kind of the reaction that I have from a lot of clients, is they say, well, if you think it's going to help, then let's do it.
Yeah.
Like
Yep.
you're the doctor, right? You're like, I'm
Yeah.
coming to you with this problem. Um, but you're totally right. They're in control the whole time. And so often when I have somebody who is afraid or fearful of doing dry needling because they're unsure of what to expect, the anxiety or the building it up in their mind really ends up being worse than what they actually feel when we do the dry needling. I've had
Yeah.
so many people who are hesitant to do it. Not that I talk them into it, but I kind of talk them down from like it's not going to be that bad. And if it
Yeah.
is, we'll be done in, 30 seconds. But then we do it and they say every time, that wasn't so bad.
That
We
wasn't
can
so
do, we can do that again in the
bad.
future, especially if they notice that it helps. But the funniest thing I have noticed, it seems to be a trend. Sometimes the people that are the most fearful in the office with me, who don't want to do dry needling, are just loaded with tattoos, right? They have a sleeve and they
Yeah,
have a
that's right.
big back tattoo or a shoulder tattoo or whatever. And I'm not sure about you, but I have one tattoo, and the discomfort from that is significantly more to me than doing a session of dry needling.
Yeah, no tattoos here. I have been regularly treated myself with dry needling.
Mm-hmm.
The I'll just be honest with you. I don't love it,
Yeah,
but I still do it because I know what the effects are and how I feel after I'm done.
totally.
I maybe I should tell you about this. I experience a little bit of low back pain myself. Have
Mm-hmm.
some what we call a radiculopathy with some symptoms that travel down my buttock, down my leg, and down into my foot on the left side.
Yeah.
I largely can control them myself or have a colleague help me out with some manual therapy or that type of thing. But it's been probably, what was it? It was in 2017. I had a pretty significant episode where it was kind of this burning sensation down my leg and even a feeling of fire in my foot.
Yeah.
I had some well-trained colleagues in the realm of
Mm-hmm.
mechanical diagnosis and treatment. They call it MDT, and they gave me a prescription of what I should do. And I said, look, my first inkling is to just go get dry needled, but I want to try what these guys are suggesting
Yeah.
because there is some decent evidence behind MDT. So I did it, and I said I'm going to do MDT for a week, and I I made it for 3 days. And at the end of 3 days, I hadn't slept very well. I was kind of dragging a foot in the clinic. I walked in the clinic one day, and one of my colleagues, who's a fantastic practitioner, she said, lots of experience, 20 years of experience. She said, "Why are you limping?" Dude, I was barely limping, but a trained therapist can tell, right? And
Totally.
she's like, "Why are you limping?" And I told her, and she said, "Well, let me finish up my patients for today." She had a full schedule of like 15 patients. She said, "Let me see my patients, and then I'll see you."
Mm-hmm.
So she evaluated me real quick. She's like, "Why haven't we needled you already?" I said, "Oh, I was trying this MDT thing." She's like, "Well, I know MDT." She's like, "No, we can keep doing that. That's fine. Let's do this."
Yeah.
And all she did, she just stuck two little needles in my back, two in my foot. She connected some e-stim from one at the back to one in the foot, and then another
Mm.
one at the back to the other one in the foot. So she ran that stim. It was at 100 hertz. So just kind of like this buzzing feeling down my leg for 20 minutes. And she's like, "Don't move, just, play on your phone or whatever."
Yeah.
Dude, I got up from that 50% improvement from the very beginning.
Nice.
By the time I went to bed at night, 75% improved. By the time I woke up, it was pretty much back to its normal,
Just kind of
5%, just
there.
kind
Yeah.
of there, right?
Mm-hmm.
And and hey, I have had patients that have benefited greatly from an MDT approach. I
Mm-hmm.
have colleagues that are very successful with doing that. And that should be part of my toolkit. It is. Like I said, I have patients that I do it on, but I am not going to forgo or wait 2 or 3 days again. I'm just going to
Yeah.
get it done. You know what I mean?
Yeah.
It has that kind of effect. And not only on myself, it happens for a lot of patients.
Yeah.
Now, it's pretty fair to say that the evidence shows this, 6 to 8 treatments is pretty normal for to get that through that reset and into the restore kind of phase, right?
Mm-hmm.
But I do have on occasion patients where one treatment and they're done, right?
Yeah.
One
Sure.
in particular is a guy that came in with temporomandibular disorder. He was actually a friend of mine, and this was right at a time, it was the week I was moving from Georgia to Florida. And he's older than me by about 15 years, but we were on this service organization together, and he mentioned his jaw pain. I said, "Hey, you should come and see me before I leave." So he did, and I needled both sides of his jaw, and he got up. He said, "Yeah, that feels a little bit better." And then I moved, and we're still friends on Facebook. A couple months ago, I posted some pictures of a class that I taught, including that protocol for the jaw,
Yeah.
and he messaged me underneath it. He's like, "Hey, haven't had a jaw problem since you needed my jaws
That's
6
awesome.
years ago, right?"
Yeah.
So he was a one and done kind of guy, right? But those you'll see those too. But for most people, it's probably fair to say 6 to 8 treatments that they'll progressively get that under control.
Yeah, yeah, for sure. And I've had those similar types of things too, where some clients see success over the course of several treatments. Some see a huge change in one treatment. I'm curious with your teaching, right? Teaching continuing education courses on dry needling, spinal manipulation, teaching in the university setting, specifically on the dry needling side of things. What are some of like the most common questions that you get from some of your students, from some of the the PTs that are taking these continuing ed courses about dry needling? What are the most common questions that you end up answering, you think?
So a very common one, I mean, the very first one is, hey, when should I use this? And they're almost always saying, hey, can I use this for a rotator cuff tear?
Yeah.
Hey, can I use this for this? They start listing all these diagnoses.
Yep.
But when I teach a course, the very first thing I do is teach them those three things that I said needling does, right?
Yeah.
And so I'm that punk teacher that just turns the question on them and says,
yeah,
well, what is it you're trying to do?
totally.
Because in the case of a rotator cuff tear, if it's not significant enough that you need a repair, a surgical repair, but there is a minor tear there, and that usually is somewhere along, somewhere around 25 to 50% thickness tear. If we're under 50% thickness tear, then we probably should wait on the surgery, right? Mm-hmm. And in that case, well, what am I trying to do there? Because if I induce some inflammation, is that a good idea? Actually, yeah, right. I want to, because obviously that tear is not getting through this repair and remodel phase. So I stick a needle in there. I'm going to cause some inflammation. Now we're going to do some stretch and exercise, gentle in the beginning, more aggressive as we progress, and hopefully, and I know a scientific word, hopefully, but hopefully we can get that inflammation to that area to progress to a repair, progress to a remodel. So that's what I'm trying to do there. But in the case of something else, I don't know, let's say, I don't know, give me a diagnosis, some neck pain, right?
Yep.
Just general neck pain. Well, it's either due to stenosis or spondylosis, so to arthritis, right? Do I want to induce inflammation in arthritis? No.
Right.
However, high correlation between arthritis and trigger points. So do I want to try to treat trigger points there? Yes. Or probably even more of an effect. Am I trying to reduce the amount of pain that they're feeling with that release of their own opioids?
Yeah.
That's probably what I'm trying to do there. So that question that I get from students of what do I use this for? I'm like, well, what are you trying to do?
Yeah.
And then apply it that way.
Yeah, and I love that too, though, because you mentioned before, I forget what you said, what program it was. I think it was the manual manipulative program that you went to, blending the art and the science of PT, right?
Yeah.
And
the American Academy of Manipulative Therapy.
American Academy of Manipulative Therapy.
AAMT. Yep.
Because that's ultimately like what we're trying to do. One thing then, when I used to mentor, I've had a lot of students come in the clinic with me over my career for clinical rotations.
Yeah.
And, they ask a lot of questions, which is awesome. And when I used to talk with therapists that we were hiring in my previous role, or even in a current role, or with students, one of the things I always ask them when they're deciding what to have a client do, right? Whether it's an exercise, whether it's what they're going to do, if they're going to manipulate their back or try needle or whatever, it's always like, what for what? Like, what's your purpose or what's your intention of this exercise for this patient? Because hopefully you're not just like, oh, every patient with low back pain comes in and they get this sheet of exercises. That's not how we should be treating patients, right?
Exactly.
There needs to be a clinical rationale. There needs to be some sort of decision-making process that takes place. So I think you turning that around and saying like, well, what exactly what are we trying to accomplish here?
Yep.
Is a great question, because there needs to be that thought process. We're not just dry needling for the sake of dry needling, right? We're doing X treatment for hoping, like you said, scientifically, we're hoping for a certain potential result. And we're not just doing it just to check a box.
Yeah, that's exactly right. Some other questions that I might get is, hey, how long are these needles supposed to be left in the body? Because my very first course was like, piston and then pull the needle out. And
Yep.
that's not what the evidence shows us. When we look through the scientific papers on this, really a minimal effect, you need about 10 minutes of the needles left in place. And then there doesn't seem to be that much therapeutic effect after 30 minutes. So it's somewhere in that 10 to 30 minute mark that is most effective for these things. Other questions, what tissues can we affect if we're not just affecting muscle? So very common. We can affect nerve, and nerve specifically with this modality. I'm not trying to put a needle into the nerve, but we do try to get it near the nerve, and that can help. It seems counterintuitive, but initially it causes some inflammation. It very quickly can help resolve inflammation with an anti-inflammatory effect. So we can affect nerve. Tendon. Again, I don't need to be sticking needles all over inside of tendon, but if I can get them around and near the tendon, maybe the outside fibers of a tendon, it can have an effect there. Probably one of the more effective places that we can treat is where a tendon inserts on bone, or a ligament inserts on bone. If we can disrupt that tissue just a little bit, cause a little bit of inflammation there, and then a proper load, stretch, exercise modalities, then we can help those areas resolve. I'm thinking particularly, the lateral elbow, tennis elbow, or lateral spondylitis, terrific spot. I myself have been treated there for that reason. At the insertion of the tendon, the common extensor tendon, into the lateral epicondyle. Another place is the plantar fascia, right? Where the plantar fascia inserts on the heel, on the calcaneus. Try to induce some inflammation there and get that go. In fact, I was involved in a randomized controlled trial of over 200 subjects. I'm published in that area, treating plantar fasciitis with this modality. So,
love it. Well, in kind of some of these places in the body, right? If one of the goals is to intentionally try to produce a little bit of inflammation, the way that I typically explain that to clients is we are trying to facilitate a blood flow effect, right? We're trying to bring some blood flow to the area. And some of these areas may not have great blood supply. And if we can do something to just try to facilitate a little bit more, to produce a little bit more of a healing possibility, that may be very effective. So no, I think those are kind of common questions that I hear too. And I remember we were talking last week with some of the rest of our team members here at Physio Room that, like, one of the times where we maybe wait with a client to potentially do a little bit of dry needling is in a post-surgical situation, right? If they had an incision and they have a wound, say from a rotator cuff repair or a knee replacement or anything like that, we want to wait until that wound is healed and sealed before we introduce some dry needling, even though the possibility of having any sort of infection risk is extremely small. Waiting until that wound is closed it helps us bring that down even just a little bit more.
Oh, sure. Yeah. So when I was at West Point in New York, I was there for 18 months. We worked very closely with the orthopedic surgeons there. They would come every week. They'd be in our clinic and we would see patients with them. And that was very beneficial because they're like, hey, patient, see, I'm sitting here with your physical therapist, do what they say. And that was very helpful. But those surgeons were all on board with dry needling. Now they did want wounds to be closed, but the main reason they wanted us to use it was not for inflammation. It wasn't for resetting the muscle. They wanted it for the pain control. And the reason why, because almost all of their patients were cadets, and cadets don't get 3 weeks off after a surgery. They have to go to class like the next day. Well, if they're hopped up on pain meds, they're not getting anything out of class.
Totally.
And we did a randomized controlled trial with this too. Cadets that went through shoulder surgery, and half of them went the traditional route of their traditional rehab with traditional pain meds, and the other half went through rehab, but they had access to dry needling treatments, and they halved their pain medication usage.
Love that.
So they were able to go to class and pay a little bit better attention, right? Because they was hyped up on pain meds. So now, if you, I do not needle a patient post-surgically unless one, their wounds are closed, and two, their surgeon agrees with it, right?
Mm-hmm.
I need to have their surgeon on board because I don't want a patient going back to a surgeon and saying, hey, they did this cool needling thing with me. And the surgeon's like, what? I just had this surgery done. Why are they messing with my surgery? So it
Yep.
needs to be a symbiotic relationship there, so that there's no confusion or confounding treatments.
Yeah. Well, and that's only going to be better for the client and the patient at
Yeah,
the end of the day,
right.
anyways, when their providers are on the same page and
Talking.
communicating.
Yep.
Unfortunately, that doesn't always happen, but
No.
when it can, it always works out in the best interest of the client.
Yeah.
It's funny you talking about, sort of the side effects of some of these pain medications, opioids and whatnot. Like we were talking off air, I've had multiple orthopedic surgical procedures myself,
Yep.
most of which, I think I actually found out in the hospital I may have some sort of an allergic reaction to a medication called Norco, which is kind of like
Yep.
a generic, Vicodin, so to speak.
Yeah. Right.
And so the physicians opted to put me on a form of oxycodone.
Mm-hmm.
And after I had one of these procedures, I remember I should have been, at the point where I was pretty much like, there's no anesthesia and whatnot still like in my system. That's kind of all gone. But I was taking this oxycodone on a very regularly regimented routine. And
Yeah.
this was maybe like 1 full or 2 days after my surgery. And I remember having a conversation several days later with one of my good friends, and I was like explaining to him, I forget if this was a text message or a phone call. I was
Mm.
explaining to him kind of like my hip surgery and what I had done and whatnot. And then partway through the conversation, he sort of just stops me and says, Andrew, you don't remember talking to me after your surgery, do you? And I'm like, what are you talking about? He goes, we talked about this like 2 days ago. We talked about this yesterday.
Yep.
And that medication is so strong, right?
Yep.
I don't even remember conversations that I had in the past, right? It
Yeah.
totally just erased that from my memory bank. And, that was one of the experiences I had that was like, holy smokes. Like I use these like, and I only ever remember going through, a portion of my prescription. I don't think I ever
Right.
finished the full allotment, but
Yeah.
there are people that take these medications every single day
All the time.
for years, the majority of their life. And it's crazy to me because of the such strong side effects that I remember experiencing. I couldn't imagine like trying to just like function in my life like that day after day after
Exactly.
day.
Exactly.
Crazy.
Yeah. That's I love needling. For one of the reasons I love needling is for that.
Yeah.
Is that very few side effects. If I overdose a patient, it's that, and by overdose I mean I put too many needles in, or I stimulate them a little too much, or that type of thing, then the patient's going to experience some soreness and maybe even some bruising for 3 days or so.
Mm-hmm.
That we call an adverse event. That means
Sure.
I've overdosed them, right?
Yep.
So I need to be very aware of how many needles I'm putting in them, how deep I'm putting them, what kind of manipulation I'm doing to the needles, and how long I leave them in. Those are 4
Yeah.
ways that we can dose the needles. So the side effects from needling is that we're not talking about cognitive impairment, and we're not talking about long-term side effects, or
Yeah.
even
And that's
short-term.
another,
Really, applied correctly, it's not even short-term side effects. I mean, there just
yeah,
aren't.
that's another question that I get often is, well, what are the side effects going to be? Or even if I don't
Yeah,
get that question, I volunteer that information
yeah, for
for
sure.
people just so that they know what to expect. Similar to exercise, right? There's side
Yep.
effects to exercise. If you
Yep.
overdo it a little bit on bicep curls, well, your arm is probably going to be sore for
Yeah,
somewhere between 24 and 48 hours.
that's right.
But one of the other things that I usually tell people or they ask is, because they've experienced this with other types of things that puncture the skin, other types of shots or injections, which obviously these needles are significantly different, significantly smaller, thinner, monofilament, meaning there's nothing inside of them. It's not like we're injecting something, hence the term dry needling.
Right.
Like, is it going to bleed? Am I going to bleed? And honestly, in my experience, a very small percentage of the spots where the needles go in actually have a spot of blood. Maybe 10%, 15, 20, I don't know, a pretty small number. And clients are oftentimes surprised by that. But, you did mention bruising is a possibility. So.
It's a possibility. Like it should be, if you're properly trained, it should be rare, right?
Yeah.
Bleeding, you are inserting a needle in the skin, so the potential to have a drop of blood is there. But of course, we stand at the ready to kind of clean that up and
Sure.
dispose of things appropriately. It's just, it really, even though we're sticking a needle in the body, it is a minimally invasive technique. It really
Totally.
is. And for the most part, it is a safe technique.
Yeah.
Again, if you're properly trained. So
Mm-hmm.
the side effects, the risks are extremely low.
Yeah. And I think I like to think about things in this kind of like risk reward kind of situation.
Sure.
And in my mind, as either the client or the provider, the rewards far outweigh the risks typically with dry needling. And of course, we're going to, as the provider, we're going to kind of grade or structure how we do dry needling based on the level of irritability that the client has.
Sure, yeah.
If they are really flared up, maybe we're going to do a less aggressive form of dry needling. If they are really doing pretty good and we're really trying to facilitate this inflammatory response, maybe we're going to do a little bit more aggressive form of dry needling on the patient that we think is right in that situation.
Yeah.
I get
you're
asked
talking
by
about dosing. You're dosing
totally
appropriately. Yep.
Mm-hmm. I get asked by clients all the time. I work with a lot of runners or athletes. Can I still go exercise after we do this? Or can I still go for a run after we needle my quad or whatever? And the answer is absolutely yes, right? Like you said, it's minimally invasive. We're not doing something that's going to prevent you from functioning. And the cue that I normally give people, just so that they don't experience significant side effects, is yes, I absolutely want you to go move. I don't want you to go sit around the rest of the day. We're trying to facilitate this blood flow response. But just don't make it the most intense or longest volume training session that you've done in recent memory. If you've been running 5 miles a couple times a week, don't go try to run 15 today. But just do something normal for yourself, and you're probably going to be a little bit more aware of that area. You're going to have a different sensation there. It could be a little sore, but there's no reason you can't go do that.
Right. So I did say we're inducing some inflammation. We are causing some damage. Now it is very focal. It's very minimal, but the damage is there.
Yep.
So I simply tell patients, hey, today is not record-breaking day, right? It's not one rep max day. It's maybe 50% load. It's going for a jog instead of a sprint. It's backing things off. You do need to move. The only way that the inflammatory process works is with movement. It can't work if you're just sitting around. So inflame, repair, remodel, that happens with movement. So yeah, let's get out and move. I typically end my sessions with patients going through their exercise program. And I'm not saying do the exercise, just they review with me what they're going to do for their program at home. And that starts a little bit of movement,
Totally.
It works out pretty well.
Yeah, I'm with you too. I rarely, it happens, but rarely do I have dry needling be the last thing that I do with a client for that reason. I usually want to get a little bit of movement going afterwards. And that usually seems to work really well. So what else, Nate? What are we forgetting before we kind of start the process of kind of winding this down and wrapping this episode up? Is there anything else that you tend to talk about pretty commonly with dry needling that we haven't already touched on in this episode? I think we've hit on some really good things. I think we gave a very good overview of, kind of what dry needling is, kind of why it may work for people. We've kind of explained it at the level of providers, as well as hopefully what most clients can understand. And, but are we missing something?
I think I would just end with maybe a list of conditions that this is really good for. And I know I just got through saying, hey, I just want you to think of what you're trying to do and then apply it appropriately. And it's not just, hey, this condition, I do needling, this condition. I still want you to think through that process.
100%.
I'll tell you what, this for plantar fasciitis, it's near home run, man. If anybody has
Mhm.
questions about plantar fasciitis, please call me and let's talk about it. And I'll go over the study with you, or I'll send you the study and you can read it for yourself. Uh, Knee osteoarthritis. We have a couple of randomized controlled trials in place now for arthritis of the shoulder, arthritis of the hip, but the one for the knee, it's been done, and it was done with over 200 subjects. And if you're trying to delay a knee surgery, you need to start getting the appropriate intervention for dry needling for your knee.
Mm.
Uh, let's see, another good one. We mentioned temporomandibular disorder. Just do it, right?
Yeah.
Your dentist. I talked with a dentist yesterday about this. Uh, he is so tired of putting splints in people's mouths to try to treat temporomandibular disorder.
Yeah.
And there are some that try to do some mobilizations and to do like muscle massage of the pterygoids that are responsible for some of your jaw movement.
Yeah.
Guys, we can reach that so easily with needles. Just do it. I've had several people write me back from courses saying, hey, I use this to treat headaches in my patients. 3 treatments and they were done.
Hmm.
What are some other conditions? Oh, scars.
Yeah.
This can be used really well for treating painful or immobile scars.
Hmm.
So just find somebody and just get it done. So that's a list of conditions that, gosh, tried and true. Let's just do it. Oh, another one we've got in a randomized controlled trial right now is Achilles tendinopathy,
Hmm.
and another one for lateral epicondylitis for
Yeah.
the tennis elbow. Um, I can tell you anecdotally from my own experience for the tennis elbow, just get it done. Don't waste. We're going to do other stuff too. We're going to do some eccentric exercises and all of that, but
Yeah.
let's add needling to that too. Yep.
Yeah, I think that's a good point, and honestly a good list. All those things that you just listed off, I feel like I've had success with dry needling
Yep.
for clients that are dealing with all of those things. Um, really see a huge benefit in that tennis elbow, lateral epicondyle sort of side of things. And then, so many other things: back pain, neck pain, shoulder
Oh, sure,
pain,
sure, sure.
you
Yeah.
name it, right? I needle a lot of calves on running clients that I work
There you
with,
go.
and they all seem to have a positive effect of that. It's really an awesome tool in the toolbox. Like Nate just said, it's not the only thing that we're going to do, and it shouldn't be the only thing that we do. And part of the reason I say that is we will have potential clients a lot of times call the office and say, do you do dry needling? Or I want to get dry needling.
Hmm.
Though I think that's a very valid and appropriate question to ask, I still would encourage any client to, even if you think dry needling is going to help you, like that should still be part of the clinical decision making process with the provider that you're
Yep.
going to be working with, because it may be appropriate, but it
Hmm.
might or might not be appropriate today, right?
Right.
Or the next time, or every single time you come in the office, you may not need dry needling. And, but it can be an awesome tool. All of our providers, our rehab providers at Physio Room, do specialize in dry needling. And what's cool is we've had a variety of different courses and, teaching styles that we've learned through. So some of us dry needle slightly different than others, but what's awesome about that is we get to kind of blend and mold those things together and talk about what seems to work for each of us. I can tell you that my dry needling technique has changed over the past several years, and I try to just take the best of both worlds from what different people have talked about and used. So I think this conversation, this episode, has been awesome, Nate. I really, really
It's been
appreciate
fun.
you joining me here and talking
You
through
bet.
dry needling. And for all of you guys that tuned in here on this episode of The Code, again, really appreciate your time. And if you found something of this valuable to you, if you would like to leave us some comments, please go hop on the review section of whatever podcast platform or website you're using to listen to this. Drop us a review and maybe ask us some questions about different topics that you would love to hear about, so we can get an episode out on those things as well. So we'll catch you guys back here on The Code for another episode in the future. Again, Dr. Nate, enjoy the rest of your day, and thank you so much for joining me.
You bet. It's been fun.
All right. Thanks, guys. Catch you next
Thanks.
time.